Now we're moving to the second session for, under the NCDs title. We will start with Dr. Maysoun Abu-El-Noor on behalf of Dr. Zaher Abu-El-Noor. Dr. Maysoun will be presenting a presentation entitled, "Will the use of mobile phone application improve adherence to treatment regime among hypertensive patients? A clinical trial study." Dr. Maysoun is a PhD holder in healthcare policy from University of Akron, Ohio, United States. She has a Master of Nursing Management from Al-Quds University and a Bachelor of Science in Nursing from the Islamic University of Gaza. She's currently an Associate Professor at the College of Nursing, Islamic University of Gaza, Palestine. Started her work at the Faculty of Nursing at the Islamic University of Gaza as a teaching assistant in 1997 and promoted to the position to Associate Professor in 2017. So Dr. Maysoun, go ahead with your presentation and hopefully everybody can mute their mic so we can listen to her clearly. Thank you very much.
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. This is Maysoun Abu-El-Noor, Associate Professor at Faculty of Nursing at Islamic University of Gaza. Today, it's my honor to share you with one of our research experiences. It was about impact of mobile phone app on adherence to treatment regimen among hypertensive patients, a randomized clinical trial study. As we know, hypertension, the silent killer, is responsible for half of heart diseases and cerebrovascular accident-related deaths over the world. Unfortunately, only 20% of hypertensive patients have control over their blood pressure. In the Arab region, the incidence is higher and the rate of control is lower. Regarding Palestine, in the year of 2018, hypertension was responsible for about 4.5% of heart diseases-related death in the area. As we know, there is a growing evidence about the effectiveness of health-related mobile apps on the adherence level among chronic patients. So the aim of this study was to assess the influence and effectiveness of using phone apps on enhancing level of adherence among Gazan hypertensive patients to hypertensive treatment. We have several questions in this research, but the main questions wandered to discover the level of adherence among Gazan hypertensive patients and to determine the degree of effectiveness of using mobile apps on enhancing this level of adherence. To conduct this study, we targeted all adult hypertensive patients who are above 18 years, who have been diagnosed for at least 1 year with hypertension and take at least one kind of antihypertensive medications and are registered in any of governmental or non-governmental primary healthcare centers around Gaza Strip. To conduct the study, we use two phases. In the first phase, we use cross-sectional method to assess the level of adherence among participants selected from convenient sample of 689 participants. These participants should have smartphone, should be able to use this smartphone and should read Arabic. And we assess the level of adherence among all of these 689 participants. From these participants, we just find 218 participants who had low to moderate level of adherence. They scored about 26 score using the instrument in this study. So we just selected these 218 participants and randomizedly assigned them into two groups. The intervention group and the control group. On what basis we assess this level of adherence? Actually, we use the instrument called Hillbone Compliance to High Blood Pressure Therapy Scale, which was developed by Tim and his colleague in the 2000 year. But we added a part of demographic data asking about age, gender, location of residency, vacation, or job, in addition to some information about health history, focusing on length of hypertension, diagnosing any type and kind and number of antihypertensive medication, any kind of complications of hypertension or other chronic diseases. Regarding to the Hillbone Compliance to High Blood Pressure Therapy Scale, actually this English instrument is divided into 3 domains. The first domain focus on medication adherence, the second focus on adherence to diet regimen, while the third focus on adherence to medical appointment using 14 items. Looking at the very particular food culture in Gaza Strip, where people prefer very hot and very salty food. So the researchers saw it is important to add a 15th item to ask participants about their adherence to abandon such kind of food. After translating this instrument into Arabic, then translate it into English by several very fluent bilingual healthcare providers. We used this instrument. Actually, each item in the 15 items was measured in 4-point Likert scale. The first is 1, associated with never, 2, associated with occasionally, 3 refers to often, and the higher score is always, which takes 4. Before conducting this instrument in the study, we asked 10 participants to participate in piloting study, and the Cronbach alpha was acceptable. It was 0.745. As I mentioned, we just got 218 participants to be eligible to participate in the intervention phase. For these people, we developed a phone application, and this application actually was designed to perform 4 tasks. The first task to deliver remaining alarms to this patient to take their medication daily, and every alarm was tailored for each participant according to the frequency of his medication. The second task to send a monthly or less message to alarm these people about the next appointment of follow-up. The third task actually was different. It was to send about 90 randomly health educational related messages to educate these people about hypertension, its causes, diet regimen, lifestyle changes, and its complication. And these messages were sent on daily basis. While the fourth task actually was to offer this participant with space on their smartphones to have a blood pressure measurement area so they can follow up the readings of their blood pressure over 3 months and compare this with their healthcare providers. Again, before using this app formally, we asked 10 participants to participate in piloting study. We make some modification to make this app is very, very easy to be used on all types of smartphones. Of course, This app just was sent and given for people in the intervention group, while the control group participants received nothing. And after 3 months, we recollect the data again. For data analysis, of course, we use the version 22 of SPSS. We use data collection, data cleaning, double checking with data entry. For data analysis, to describe the sample, we use means and standard deviation for continuous variables, and use frequencies and percentages for categorical variables. To compare the level of adherence in the 3 domains and the total score of level of adherence of participants in the both groups, we use ANOVA, chi-square, and T. I think most of you are excited to know the result of this study. After 3 months, we just be able to reach 191 from the 218 participants in the post-intervention phase, 94 in the control group, and 97 in the intervention group. Among the reasons for attrition, we find incorrect phone number, not responding phone number, phone call, I'm sorry, one case of death, and some travel abroad the Gaza Strip. As I said, after 3 months, we reassess the level of adherence in both groups. And for surprise, we found that the level of adherence was improved in both groups. Does this mean that the apps was not effective? No, absolutely no. The apps was effective, alhamdulillah. Since we found the impact on the intervention group was significantly stronger compared with the control group. To understand what I say, let us look at this table. In this table, we compare and see the differences among the means of health compliance to high blood pressure, therapy scale between control and intervention groups after intervention. As I said, in the pre-test, we didn't find a large a difference in the level of adherence between the control group and intervention group. We found in the control group it's 31.1, in the intervention group it was 30.82. But after using the apps, the level of non-adherence dropped from 31.1 to 27.38 in the control group, and in the intervention group it dropped from 30.82 to 23.40. This was in the total score, but of course it was also in the 3 domains, but the major difference was observed in the medication adherence. To ensure ethical consideration, we got approval from Helsinki Committee, the Research Ethics Committee in Gaza Strip, as well approval from the Ministry of Health and Palestinian Medical Relief Society, and we asked every participant to sign a consent form. Of course, the data collector were trained and were selected away from the primary healthcare centers where participants were selected. As any other study, this study has several limitations. We have some limitations associated with the small sample size due to limited fund. We have some sample selection bias, since we got just people who are registered in the primary care centers, just people who had a smartphone and be able to use this smartphone and read Arab, and exclude other patients who are not registered in these centers, in addition to some expected bias due to self-reporting data. But this can't impede the strength of this study, since it is the first study assessing this topic in Gaza Strip, and actually it is one of the very few studies in the Arab region. In conclusion, we can say that congruently with the result of other several studies, the results of this study revealed the effectiveness of mobile phone apps in improving and enhancing level of adherence in the all 3 domains and in the total score, focusing in enhancement on medication adherence domain by hypertensive patients. For this point, we can claim that using mobile apps may increase the patient's adherence level and congruently decrease the complications, morbidity, and mortality among hypertensive patients, and maybe among other chronic patients. On the aspect of practice, we can say that using mobile health technologies offer a very easy to use and widely accessible strategy that can improve the level of adherence and improve the health of people, especially in low-income setting. For this reason, I send a call for all of my colleague researchers to reapply this topic in a larger sample for longer period in different areas and to conduct similar research for different chronic diseases. Thank you very much for your listening and have a nice day and have very productive research conference.
Thank you very much, Dr. Maysoun, for your presentation. And I think your research is very timely since now everybody is moving toward digitalization health, using the maximize the utilization of digital applications and initiatives. I would like to take this opportunity since Dr. Maysoun is with us and she mentioned an electricity problem to see whether we have any questions, and if we don't have any question, we can move to the next presentation, but okay, we can see hands here. So Professor John Yatkan, go ahead.
My anxiety is that self-reporting of adherence to good health behaviors is very difficult to be objective about. When my dentist asks me how many times a day am I brushing my teeth, I say twice. Do I floss my teeth? Yes. If I undergo a dental behavioral change intervention that says you really must brush 3 times a day and floss every day, when I go back to see the dentist and I'm asked how many times you're brushing and flossing, I am unlikely to tell something that is uninfluenced by what I've been told to report. This is particularly the case in dietary questionnaires. I've always been nervous about nutritionists giving an intervention to do with dietary advice for people with diabetes and then doing a before and after dietary adherence questionnaire, even if it's a different person. The reporting of saturated fat, sodium intake is likely to be biased by what you're supposed to report. Are there any more objective ways of getting measures of adherence? Clearly, in a more high-tech setting, you could look at pill box recordings of opening and tablet counts, which would be a better way of looking at medication adherence. Do you mentioned the limitation of this methodology, but do you agree that this is a problem in your self-reported results?
Dr. John, I'm sorry, the electricity and the internet is very bad. I couldn't hear you. Just
to summarize, Dr. Maysoun, his question is, you used subjective self-reporting measures, so you relied on the patient's responses.
Yeah,
and he was asking if there is a more objective way of collecting such information. It seems that we lost you, Dr. Maysoun. Okay.
The patient. Yeah. Okay.
Yeah, go ahead.
As I mentioned in the presentation, and that we know this self-reported is not objective, and we can't rely on it absolutely, but it is very difficult to assess it more objectively. I think if we return to the doctors, or if we return to the clinic where they receive the medication and see if they have medication or not, so this may help, but it will not be absolutely. Do you think if we use the diary from the family member, I mean, if we ask the family member to observe the patients if he or not take his medication or not, or if he or not comply with the regimen, data management and regimen, I think in our situation in Gaza, in very, very strict situation, it will be very objective assessment, because sometimes the physician asks the patient, why you didn't, how many tablets or how many pills do you have in your bottle, to assess if the patient is complying or adhering with the medication or not. But even this, I think it's not 100% reliable method. So I think if we have more time and if we have more budget, this may help us to contact the family member the patient have, or to return the file of the patient in the NC if he take the to the, I mean, the amount of medication monthly, not because if he has the medication, so he will not go to take it from the clinic.
Thank you, Dr. Maysoun.
You're welcome.
We have a question from Dr. Zaher. So, Dr. Zaher, you can ask the question and then we can move into your presentation.
Welcome.
Thank you. Really, I would like to thank the researchers for this type of research and the idea, really great type of research that we need for the benefit of our patients.
Thank you.
I would like to see if there's a link to more data about such a study, to know more information about the intervention, how was designed, how was the validity of such an intervention was tested, and all of this information. Also, I would like to know the control group, why there was an improvement in their compliance. Was the randomization based? Was it a cluster randomized trial, or from the same clinic you have some patients in the intervention or in the control group? And maybe to solve the issue of self-reported data and subjective way of measuring the outcomes. Maybe I missed this in the presentation, but did we measure the blood pressure? How was their blood pressure? The blood pressure control status, did it differ between the two groups? Is my specific question.
Thank you very much. First, we published a paper about this research. So if you like, we can send the article for you to see more information about the result. About the subjectivity of the self-reporting, we again, since it is one of the limitations of the study, write this point. About assigning the patient into random or control group, we use simple random. So randomly we assign them to the control group and intervention group. They are not from the same clinic. We used several clinics, as we said, around the Gaza, because we have in Gaza Strip, we have 5 governorates. So we tried to cover these governorates geographically, and we used some governmental and NGOs clinics actually, because they were easy to access patients there, but the UNRWA actually we couldn't reach them. Again, your question, why they have improved the adherence, and you asked if we measure the blood pressure or not. Actually, we didn't measure the blood pressure, but as a part of the application, we put a diary for the patient to measure his or her blood pressure and record data. So when he go to the appointment, he shows his physician or her physician with record. But we rely on the score of self-reported adherence to the medication, to the diet, and to the follow-up appointment. We didn't mention anything about the measurement of blood pressure for this patient, because it will be very costly, will take a lot of time. This research was a part of a funded project, and we had a short time to finish it. So we didn't mention the blood pressure measurement or recording, because it's not indicating always or every time about the adherence. Just we ask the patient, did you take your medication on time? Did you abandon the salty medication, food or fatty food or something? Are you adhering with the appointment? This is what we asked actually. So it's about self-reported adherence, not more than.
Thank you very much,
I
Dr.
hope I
Maysoun.
answered your
Yeah.
question, Dr. Zaher.
Yeah, I will keep, please, if you can, if the electricity allow, please stay with us until Dr. Zaher finishes his presentation, and hopefully we'll have more questions
actually,
for
but
you
the internet
and
is
for
very bad.
Dr. Zaher.
I heard about 30%.
Yeah, it's okay. Try to stay with us until Dr. Zaher finishes his presentation, and then we will have a joint discussion. So now we will move to
it's my honor
our
to
colleague.
actually hear.
Yeah, thank you,
Dr. Zaher.
Now we'll move to my colleague, Dr. Zaher Nazzal, the quiet researchers, if I may say. So today, Dr. Zaher will present the prevalence and risk factors of chronic kidney disease among Palestinian diabetic patients from a cross-sectional study. Dr. Zaher is an associate professor of community medicine, graduated from Istanbul University, Faculty of Medicine, Turkey. Currently, he is working at An-Najah University at the Faculty of Medicine and Health Science, Family and Community Medicine Department. It's a very complicated title. He is the head of research unit with more than 40 publications in peer-reviewed international journals. He has supervised several master's students, and he is a member of the community medicine community, the Arab Board of Medical Specialization, and the family medicine community, the Palestinian Medical Council, and the community medicine community from since 2014 until now. So Dr. Zaher, the floor is yours, and we look forward to listen to your presentation.
Thank you. Thank you. Hi, everyone. I'm Dr. Zaher Nazzal from An-Najah National University, the Faculty of Medicine and Health Sciences. I'll be presenting our research project on the prevalence of chronic kidney disease among diabetic patients in Palestine. I'm presenting this work. I'm presenting this work on behalf of our research team, Dr. Zakaria, Dr. Dunya, and Dr. Odai, Dr. Muhammad. Diabetes mellitus is known to be higher prevalent at the global level, and is known to be as the fastest growing chronic kidney disease. 1 in every 11 adults has diabetes mellitus. 90% of them have type 2 diabetes mellitus. This scenario is not, the Arab countries are not excluded from such a scenario. Unfortunately, most of them are burdened with a high prevalence of diabetes. Palestine as well as suffering such a burden. 15% of the adults in Palestine were found to have diabetes in 2010. 20% of the population is estimated to have it in 2020, and this number are projected to increase to 23% in 2030 unless preventive measures are taken. Reviewing the Palestinian Health Annual Report of the year 2019, we found that almost 1/4 billion primary healthcare visits are related to diabetes mellitus, and the incidence was reported at 80 cases per 100,000 population. Adding to this, we have almost 90 diabetes mellitus related deaths were reported in that year. Chronic disease is as well very important morbidity, and it's highly prevalent at the worldwide, at the global level. It is defined as the structural and functional abnormalities present for more than 3 months with health implications. Diabetic kidney disease were found to increase by almost 40% from 2005 to 2015. And this increase were attributed to the chronic effect of diabetes mellitus hyperglycemia. It is a major public health problem in terms of the cost of morbidity and the treatment and high utilization of healthcare services. It was found to be associated with renal failure and progression to with decreased renal function and progression to renal failure, and also was associated with increased cardiovascular risk and overall mortality due to all causes. Early detection of chronic kidney disease can delay or avoid deterioration of kidney function, and this can be done through using avoidable interventions that suit developing countries like Palestine. Adding to this, identification of risk factors is also important that can help to the development of preventive measures that can prevent diabetes mellitus and its complications. The objectives of this study were to estimate the prevalence of chronic kidney disease among Palestinian diabetic patients and to identify the association between chronic kidney disease and patients' background and clinical characteristics in terms of gender, age, smoking, and other variables. For this purpose, we conducted a cross-sectional study that targeted all adult Palestinians with type 2 diabetes mellitus more than 18 years of age. The study was conducted between 2018 and December, between September and December 18 in the Ministry of Health Primary Health Care Centers in the North West Bank. Patients with type 1 diabetes, gestational diabetes, and pregnant women were excluded from the study, in addition to patients who didn't have at least 2 serum creatinine readings of at least 3 months were also excluded. We calculated the needed sample size, which was found at 385 patients needed for this study. Patients were selected at random who agreed to participate on voluntary basis, were interviewed to collect their data, and also we reviewed their records for completing their data. Chronic kidney disease for this study was defined as patients with end-stage renal disease less than 60 in 2 consecutive occasions, at least 3 months apart. This table shows the background characteristics of the participants. Male to female ratio was almost 1. The age, majority of the participants were more than 60 years of age. 1/3 of them were smokers, and the majority were obese. The mean body mass index was almost 33. One eye-catching result of this study is the hypertension among our patients. It was found to be high. 75% of them reported to have hypertension. This result is consistent with a study conducted in Jordan. However, it's much higher than neighboring countries like in Qatar and Saudi Arabia. The high prevalence of hypertension among our patients could be attributed to the fact that most of them are obese and most of our participants are more than the age of 60 years. However, the high prevalence of hypertension is worrying and should be taken into consideration. For the chronic kidney disease, we found that almost 24% of our participants have chronic kidney disease, and that range from 19 to 28% at the population level. Worldwide, the prevalence of chronic kidney disease is variable and is different between different countries. And this difference and this variability is mainly associated to difference in the definitions adopted by different studies and different characteristics of the studied populations. Worth to mention that similar data from surrounding countries are lacking in this regard. This table presents the finding on GFR in relation to background characteristics. We found negative correlation with age, systolic blood pressure, and hypertension duration and diabetes duration. As these variables increase, GFR unfortunately decrease significantly. Also, we conducted univariate and multivariate analysis to assess the factors associated with chronic kidney disease. In the multivariable analysis, we found age, hypertension, and smoking to be associated with chronic kidney disease. Hypertension patients were found at almost 6 times more likely to develop chronic kidney disease compared to normal hypertensive patients. And this is consistent with the literature. A Japanese study found that high blood pressure patients are 15 times more likely to develop end-stage renal disease. This emphasized the importance of such findings where these patients are really at higher risk to develop end-stage renal disease. That's why they should be targeted and screened and managed aggressively. Also, smoking was found to be associated with chronic kidney disease. Recent meta-analysis indicated evidence of cigarette smoking as an independent risk factor for chronic kidney disease. Another important finding from the literature is that the risk of chronic kidney disease increases with frequency. We mean that as the frequency of smoking increases, the risk of chronic kidney disease also increased, and this due to the non-nephrotoxic effect of smoking. These results are important and emphasize the need of primary healthcare physicians and those who treat diabetic patients to really counsel them on their smoking habits and behaviors. Age was also found to be associated with chronic kidney disease, and this could be due to the fact that the GFR really decreased with normal aging, and this age groups, older age groups, have higher comorbidities than younger age groups. However, this emphasized the need to rigorously screen for diabetic patients with an emphasis on elderly diabetic for chronic kidney disease. One of the main strengths of this studies is that we targeted primary healthcare centers where almost all Palestinian diabetic patients are registered and being followed up there for free of charge for their management and medications. Also, the diagnosis of the CKD was based on eGFR on multiple measures to establish chronicity. However, the study's results should be taken into consideration with some limitations. One of it is the cross-sectional design of the study, which prevent us to make a causal association between chronic kidney disease and the studied risk factors. Another limitation is the lack of data on albuminuria and renal biopsy that make it difficult to diagnose stage 1 chronic kidney diseases. In conclusion, the chronic kidney disease is highly prevalent among diabetic patients in Palestine, and it is higher among hypertensive and smokers, and it increases with age. Based on that, we recommend that intensive screening of diabetic patients really should be taken into consideration, more aggressive treatment of diabetics, and especially those with hypertension and smoking at elderly age. For future research, we recommend follow-up study to study the effect of anti-diabetic and antihypertensive medications on the development of chronic kidney disease. Also, this group of patients we recommend that should be followed and evaluated for progression to end-stage renal disease and dialysis in each eGFR category. Thank you for this opportunity, and thanks for the Ministry of Health, for An-Najah National University for their support. Thanks for physicians in primary health care, and great thanks to participants in this study.
Thank you very much, Dr. Zaher. It's a very, very, I would say, painful results. Listening to the session, this session and the previous session, we're reporting complications of diabetes. Unfortunately, we're not reporting good news. Most of the studies are reporting high complications. Few studies, the intervention, the one presented by Dr. Maysoun and the other presented by Dr. Asma, showing some initiatives to propose way to reduce the burden of NCDs. And I wish if some of the audience or any of the audience is from the Ministry of Health or UNRWA to listen to the size of the problem and the magnitude of the complications we're facing. Hopefully, I'm suggesting now for the LPHA coordination team to send these recordings to policymakers. Try as much as you can to advocate, to make these papers and this research reach the policymakers in a way. So I'm using my privilege of being a chair here. So because I was a little bit moved by how lots of research has been done on NCDs and we cannot see any improvement. We're reporting high complications in the eye, in the kidney, oral health, etc. So I am a little bit moved by these presentations. I will stop here and will open the floor for questions. Let's start with see if we have any question for Dr. Zaher, or if you have any question for Dr. Maysoun for both presentations. If not, I have a pile of questions. So let's hear from the audience first, and then I will take the privilege of being a chair. So any question from anybody? If you can notice any eye, any hand going here and there.
Dr. Niveen.
Yes, go ahead. I can't see who's speaking. Go ahead.
Ita is talking.
Yes, go ahead.
I want to ask Doctor who presented for the from An-Najah University. His studies is so exciting, but I was looking through his presentation about the confounders. He didn't mention anything that he make adjustment for any confounders. Can he clarify that if he had some confounders for his study or not? Thank you.
Okay.
Dr. Zaher.
Okay. Thank you for giving this opportunity really and to present such work. Really, diabetes is important. Specifically in this study, as I said in my last slides, we did like a multivariate regression to control for some confounders in terms of age, gender, and body mass index and others. So we controlled for some confounders. But we couldn't, and we said in the limitation that there are other confounders that we couldn't predict during the study as a limitation. But we controlled for the non-confounders like body mass index, gender, and other variables. I will check in the table, which like diastolic blood pressure, hemoglobin A1C, diabetes mellitus duration, gender, and age. These were the confounders that were checked for in the multivariate logistic regression.
Thank you, Dr. Zaher. I would like to draw your attention that Dr. Zaher has posted the article in the chat, so you can download the full article, which is now already published, for more details. We have Dr. Maysoun. She has a question. Go ahead, Dr. Maysoun.
Thank you very much. Thank you very much, Dr. Zaher, for this very interesting article. As a community doctor, I want just to ask you about, do you think in the primary health centers, is there any follow-up or check for renal function test annually or at least once, or if there any recommendation for the patient to follow up about the kidney function test?
Okay, here what I know, I worked for 5 years in primary healthcare centers, but a long time ago, it is routinely recommended and being practiced to measure the kidney function test for diabetic patients on a regular basis. So given that we have such results, unfortunately, sometimes the follow-up, sometimes counseling with the patients on these findings, sometimes the incompliance, as you said, because of that, I say really it's important to measure the compliance of our patients in terms either blood pressure or even the screening of the markers for complication of diabetes and blood pressure. Routinely, it is practiced and it is recommended within the guidelines, while as we know that diabetes mellitus is managed, followed and managed for free of charge at primary healthcare centers, and all diabetic patients are referred there. And it is regularly conducted there. So the question to raise here is the quality of such follow-up or applying these guidelines, the compliance of the patients, the referral system, whenever you have abnormal findings, what is the next step, how the patients, how do they deal with it. Sorry, here just to mention, maybe an opportunity to mention, as I said in my last slide about the recommendation, just now we finished with writing the proposal and getting the IRB approval and all required approvals. We are conducting another study on this type, on this cohort of population after 3 years to measure the mortality and to measure the incidence of end-stage renal disease. How many of them have been moved or unfortunately progressed to end-stage renal disease or the mortality. So many questions to raise or to assess in this scenario, although it is recommended, but the results, as Dr. Niveen was saying, they are not at the level that we wish always.
Thank you, Dr. Zaher, and I'm very happy to hear that you are going to follow up this cohort, and hopefully we'll have some let's say Palestinian context rates that we can see when the patient will move from this state to this state and develop this complication. So this is really very important. But also it's important to highlight the fact that we already have services in on the ground. And my question now, I'm not sure if there's anyone who has a question. I can't see any raised hand. But my question is, given the current application, current management process that is in the clinics, do you suggest any modification or how we can integrate the results that you have provided? Because we have already patients with complications, which means that, or which implies that the management we have is not functioning as it should be, or because we do have a comprehensive PIN approach. I think it's implemented everywhere, and it has been there since 2016. So let's say it's like 7 years on the ground, a new program. So how can you interpret this? And we're not criticizing, but we can see, we're trying to think of how we can improve or modify certain practices to reduce such complications.
Okay, interesting approach. I was the team leader who designed this intervention in collaboration with the WHO and training of more than 1,000 healthcare workers in the West Bank on the application of PIN approach. This type of research is, we can categorize it under the like audit research, where we see our some criterions or some targets are met or not. From this work, what should be done ideally is that we have to assess the service itself. Are really the patients compliant with the assessments, the periodically follow-up assessments? Are our physicians aware of the next step when discovering these patients at early stage? Are we really counseling our patients on diabetic patients on smoking, hypertension, and other important variables that can predisposed for different complications like chronic kidney disease. Do the referral system is working good when we refer our patients to a specialist to assess our patient? Do we have the feedback from that physician? All these points I think should be assessed more in depth and should be evaluated to end up with a result that, or a recommendation or an intervention that improve the quality of these services. We cannot decide based on this research what is the main problem here. More in-depth evaluation of all these factors that I mentioned, or this cycle from that start with the patient and end again with the patient, including the primary healthcare physician, the referral system, the secondary healthcare system, and ending up with the patient should be, I think, evaluated more in depth to get up with a result that can answer your question. It's very important, really, when you see just 20% of our hypertension patients are controlled. This is very alarming results. When you see our, just 1/4 of our diabetic patients are controlled, unfortunately. When you see the complication, the different complications of diabetes, given the high burden of diabetes as documented by many studies and some of them by you, Dr. Niveen, that we always go through them to update our information or knowledge about the burden of such communicable diseases, mainly diabetes mellitus. So this is my suggestion for an answer to your question.
Thank you very much. I would say then you're advocating for more implementation research that can assess what's happening on the ground and help in improving it and then scale it up. I'm not sure whether this was done during the implementation of the intervention. So do we have any other questions before we end this very interesting session? If there is no questions, then let me summarize by saying thank you very much for this session, very interesting session, and the previous one. Both, they were very useful and very important. And hopefully the recommendation of the LPHA at the end, the recommendation from this session will be taken to the closing remark, highlighting the importance of research on NCDs, but not only research, but also the implementation and follow-up management, follow-up and audit the programs and that are already there. Because people are in the field and they are working, but we want to make sure that they are doing the right thing and put them on the right track. We need more research. We need to work more closely with the different stakeholders and providers, not researchers solo, not providers on their own. We need to work together because we have a very challenging issue here. Thank you, everybody, and hopefully we'll see you tomorrow, inshallah, in day 4, and then we'll be listening to the ending remark. So thank you very much for joining us, and I hope you will stay with us for the next 2 days.